There's three that are probably the most significant. One of them is advancing age, so probably about 1 out of 7 individuals that are over the age of 70 that actually may get prostate cancer. The other risk factor is also family history. So the more first-degree relatives that are affected by prostate cancer at any age, the risk also increases. In addition to that, we also look at some genetic factors. I mean, there are some genetic markers that we have for breast cancer in particular that also can affect people that have prostate cancer. So that actually also can increase the risk of prostate cancer. And then lastly is ethnicity. For African American men, they have a much higher risk of developing prostate cancer, but generally it's much more aggressive, meaning that it can have a much higher grade of kind of changes within the cells that can actually tell us how aggressive the cancer actually is, and that will determine exactly what the treatment is going to be. For men that are Asian, they have a very low risk of prostate cancer, but if they migrate here to the United States, that risk actually increases. It's kind of a two-part question. The first part is, do I get screened or not? And if I do, what are my options in terms of what the treatment may be?
There is only one group that it's a task force that recommended no screening, but I think everyone came up in arms, and even the American Urological Association kind of spoke out against it and did agree with screening.
Or am I going to do watchful waiting or active surveillance? So watchful waiting basically is knowing that you have a high PSA, which may have taken it one step further to actually get a biopsy that has confirmed prostate cancer, and then basically you wait, rather than subject yourself to the various treatment options that are out there for men, which can also carry, some treatment-related side effects as well as complications, which really can affect one's quality of life down the line.
If you choose active surveillance, it's a commitment on the patient part that you really should come back twice a year for PSAs. You need to come back once a year, every 1 to 2 years for another biopsy to see if it's progressed.
There are some more kind of novel testing that can be done. For the PSA itself, which stands for the prostatic specific antigen, the normal range is from 0 to 4, but there is really much more thinking that it really is age specific. I mean, I think if you have someone who is 45 years old and has a PSA already of 2, you would be somewhat concerned about that. There's also what we call the free PSA, which is another test that kind of looks at the amount of circulating PSA. So the lower that number is, the more likelihood that the patient may actually have prostate cancer. So that kind of gives the urologist an idea of whether the patient should be biopsied or not. And then there's a urine test called the PCA3, which is kind of, the jury is still out about it, whether it's really that significant. But one of the things that healthcare providers look at is really the velocity or the slope at which the PSA increases. So one of the things that we worry about is that if someone has a PSA that was 2 last year and now all of a sudden it's 4, that really has doubled over a period of a year. So that would be concerning.
So it can be with your primary care physician. It can be with the urologist. Urologists often send patients to the radiation oncologist to get their perspective so patients can make informed decisions. All of these groups are hopefully on the same page, giving the same information to the patients so they can make shared decisions.